Welcome to the weekly Neurology Deep Dive. We are here to provide you with a comprehensive analysis of the latest literature in your field.
Right, and before we jump in, we should note clearly and early that this program is for education purposes only.
Exactly.
There is absolutely no commercial goal here. This is, only a summary, and we highly recommend that you read the full papers we're discussing today.
Yes, definitely read the full papers.
Yeah.
So today we're analyzing two critical papers. The first is Neurologic Immune-Related Adverse Events from Immune Checkpoint Inhibitors, Recent Advances and Future Perspectives by Kawazoe, Howe, and Suzuki.
Right, and the second paper is Triple M Overlap Syndrome in the Intensive Care Unit, Differential Diagnosis and Management by Shaw and colleagues.
Perfect. And for the neurologists out there who are short on time, here's the practical summary of today's analysis.
Basically, immune checkpoint inhibitors can trigger some severe, highly atypical neurologic toxicities.
Most notably, the highly fatal Triple M overlap syndrome. And that consists of myasthenia, myositis, and myocarditis.
Exactly. And the catch is that classic diagnostic markers like your standard autoantibodies and electromyography, well, they are frequently negative.
Right. So management requires the immediate discontinuation of the immune checkpoint inhibitor, plus a parallel evaluation for infection.
And crucially, early aggressive immunosuppression with high-dose corticosteroids combined right away with intravenous immunoglobulin, which, for the rest of this discussion, we will refer to as IV, IG, or plasma exchange.
Yeah, and you must not wait for corticosteroid failure before initiating those therapies. That's a huge point we'll get into.
Absolutely. So to start, we really need to examine the epidemiological landscape of neurologic events in patients receiving immune checkpoint inhibitors.
Right, because establishing that baseline frequency gives us the oncological context for these really severe presentations.
Exactly. So looking at a large pharmacovigilance analysis of over 48,000 cases from the World Health Organization database, we have some very specific incidence rates. Peripheral neuropathy occurs in about 1% of patients.
Okay, about 1%.
Yeah. Central nervous system and other peripheral nervous system disorders are considerably rarer. I mean, encephalitis, myasthenia, and meningitis each occur in below 1% of patients.
Wow. So the incidence rates are undeniably low, but the clinical reality is that the severity of these events is disproportionately high.
Oh, completely.
Right.
When we look at the fatality rate for myasthenia induced by immune checkpoint inhibitors, it sits at about 20%.
About 20%. That's massive.
It is. Furthermore, the onset is incredibly early. It occurs at a median of 29 days after the initiation of therapy.
Right. And all this data points to a really profound clinical survival paradox.
Yes, the survival paradox is fascinating. Real-world observational studies demonstrate that patients who experience multiple immune-related adverse events actually have a significantly longer median overall survival.
Right. The data shows that patients with multiple immune-related adverse events achieve a median overall survival of 42 months.
Exactly. And we compare that directly to 18 months for patients experiencing a single event and only 12 months for patients with no adverse events.
So wait, let me push back on this clinical tension here. If these severe neurological events indicate a hyperactive, highly effective anti-tumor immune response, well, doesn't treating those adverse events with heavy immunosuppression risk compromising the patient's oncological outcome?
That is the exact theoretical concern, But the underlying pathophysiology directly explains why we have to act.
How so?
Well, immune checkpoint inhibitors are designed to target and block specific regulatory proteins. Things like cytotoxic T lymphocyte-associated protein 4 and programmed death 1.
Right, the inhibitory checkpoints.
Exactly. By blocking them, the therapy effectively restores cytotoxic T-cell activity, which enables this durable, aggressive tumor control.
But a hyperactive anti-tumor immune response naturally correlates with disrupting normal immune self-tolerance, right?
Precisely. The immune system attacks the malignancy effectively, which extends the patient's survival. But at the exact same time, that unrestricted T-cell activation initiates severe autoimmune destruction of normal healthy tissues.
But again, aren't we suppressing the exact mechanisms extending their life?
In the intensive care unit setting, the immediate threat to life entirely supersedes that theoretical risk to oncological efficacy. I mean, the mortality rates for these toxicities are immediate and extraordinarily high.
So you just don't have the luxury of worrying about the cancer months down the line.
Right. Failing to immediately treat conditions like fulminant myocarditis or rapid respiratory failure results in rapid patient death within days. Yeah. The guidelines uniformly mandate prompt, heavy immunosuppression because the injury is acutely life-threatening. And here's the key, that survival data of 42 months actually includes those very patients who received appropriate immunosuppressive management.
Oh, I see. So treating the severe toxicity doesn't entirely negate the profound survival benefit initially provided by the drug.
Exactly. Now, because the mortality of myasthenia induced by these immune checkpoint inhibitors is so high, we really must dissect exactly how its clinical profile differs fundamentally from idiopathic myasthenia gravis.
Right, because neurologists need to understand these differences to prevent dangerous diagnostic delays in standard practice.
Yes, the rapid onset is your primary distinguishing factor. This condition typically occurs at a median of 4 months, with a standard expected range of 2 to 6 weeks after therapy initiation.
Whereas idiopathic myasthenia gravis often presents with a much more insidious and gradual onset.
Right. And the diagnostic pitfalls encountered with this specific toxicity are significant. A substantial proportion of these patients completely lack any detectable standard autoantibodies.
That's terrifying.
It is. I mean, they are frequently seronegative for acetylcholine receptor antibodies,
Uh-huh.
muscle-specific kinase antibodies, and even low-density lipoprotein receptor-related protein 4 antibodies.
Wow. And furthermore, the standard electrodiagnostic tools are frequently misleading here, right?
Completely. Electromyography often fails to show the classic neuromuscular junction transmission failure that neurologists naturally expect.
So instead of a decremental response on repetitive nerve stimulation, what do you see?
The electromyography often presents with nonspecific spontaneous activity or purely myopathic patterns.
Okay, so when a neurologist orders the standard serological panel for acetylcholine receptor or muscle-specific kinase or, the low-density lipoprotein receptor-related protein for antibodies, and it all comes back negative, it just creates this diagnostic vacuum.
Exactly, but the pathophysiology explains exactly why classical testing fails here.
Right, because it's not an isolated neuromuscular junction dysfunction mediated by circulating autoantibodies.
Precisely. Myasthenia induced by immune checkpoint inhibitors is primarily a myositis-dominant inflammatory process. It is mediated directly by cytotoxic T lymphocytes.
And these T lymphocytes aggressively target the ocular, bulbar, diaphragmatic, and proximal limb muscles.
Right. And when a muscle biopsy is performed, it reveals multifocal necrotic muscle fibers accompanied by dense endomysial inflammation.
So it's the direct physical destruction of the muscle tissue itself by T cells.
Yes. And that tissue destruction explains the myopathic patterns seen on electromyography, and it perfectly explains the complete absence of circulating autoantibodies.
But wait, this creates a massive clinical dilemma. I mean, if autoantibodies are absent and the electromyography is atypical, the classical diagnostic criteria will just fail.
They will fail entirely. The presentation features typical severe myasthenic symptoms, acute proptosis, diplopia, dysphagia, dysarthria. But the laboratory confirmation neurologists rely upon is just completely absent.
So let me ask you this. This represents a profound contradiction to standard neurological training, right? We are universally taught to get objective electrophysiologic or serologic evidence before committing a patient to heavy immunosuppression.
Yes, that is standard training.
So should neurologists abandon those standard diagnostic criteria altogether in these cases? I mean, waiting days for serological confirmation in a patient with recent immune checkpoint inhibitor exposure and rapid respiratory decline seems incredibly dangerous.
It is incredibly dangerous. The clinical evidence strongly supports relying entirely on the clinical presentation and the immediate medication history. The papers emphasize repeatedly that negative autoantibody testing should never be used to exclude disease associated with immune checkpoint inhibitors.
Okay, so what does the revised diagnostic algorithm look like?
It prioritizes recognizing the clinical phenotype of rapid bulbar and respiratory weakness, and then confirming neuroinflammation through alternative means.
Like what?
Like checking for highly elevated creatine kinase levels, or utilizing characteristic magnetic resonance imaging findings of the muscle, rather than requiring traditional myasthenia gravis serology. Given the rapid progression to irreversible respiratory failure, clinical suspicion alone must dictate immediate management.
That makes sense. And this myositis-dominant pathophysiology directly explains why the inflammation frequently spills over into other specific striated muscles.
Exactly. The cytotoxic T lymphocytes do not confine their attack to just the extraocular or proximal limb muscles.
Right, it's a widespread, indiscriminate inflammation that culminates in the highly fatal triple M overlap syndrome.
Yes, the fatal triad. Triple M syndrome is formally defined as the concurrent occurrence of myasthenia-like disease, inflammatory myositis, and myocarditis.
And it is critical to understand that this is not like three separate diseases occurring simultaneously by chance.
Right. It is a single, shared immunopathologic process affecting multiple, distinct striated muscle tissues simultaneously. And the mortality data for triple M syndrome demonstrates a severe physiological crisis.
Right. What are the numbers there?
The overlap syndrome carries a significantly higher mortality rate of about 44%.
About 44%. Wow.
Yeah. We compare this directly to a mortality rate of about 30% for myocarditis occurring with just myositis alone or myasthenia alone. The concurrent failure of the respiratory muscles, the bulbar muscles, and the myocardium creates this overwhelming and rapid physiological collapse.
And histopathology backs this up, right?
It does. Fatal cases confirm the presence of dense CD8 positive T lymphocyte infiltration in both the skeletal muscle fibers and the cardiac muscle fibers. It causes direct, irreversible tissue destruction in both organs.
So, to detect this rapidly fatal syndrome early, neurologists must strictly follow a required screening protocol for every suspected case.
Absolutely. You must check creatine kinase levels immediately upon presentation.
Because these levels can reach massive, unprecedented elevations, right? One specific series highlighted in the papers showed a mean creatine kinase of 400-799 international units per liter.
Yes, 499 is an incredible elevation. Furthermore, you must continuously perform serial troponin tests, serial electrocardiograms, and early echocardiograms.
Right, because a single baseline troponin test is completely insufficient.
Yeah.
Modest early elevations often precede rapid, catastrophic clinical deterioration.
Exactly. And there is a critical diagnostic caveat specifically regarding early cardiac imaging in these patients.
Oh, right, the MRI.
Yes, an early cardiac MRI may be completely normal despite active disease. Furthermore, normal initial biomarkers, including completely normal early troponin levels, do not exclude active myocardial inflammation.
Wait, really? The initial troponin can be totally normal?
Yes, because the inflammatory process in the myocardium can be highly patchy, or just in its very early stages before extensive necrosis actually releases detectable biomarkers.
So repeat testing of troponins and continuous cardiovascular monitoring is absolutely mandatory when the clinical suspicion for neuromuscular involvement remains high.
Mandatory. You cannot skip it.
But this inherent diagnostic uncertainty really highlights the danger of single-organ diagnostic anchoring.
Oh, absolutely.
I mean, consider a standard presentation where a patient arrives with progressive bulbar weakness and a massively elevated creatine kinase. The clinician might comfortably stop their investigation at a diagnosis of concurrent myositis and myasthenia. They have a completely rational explanation for the symptoms.
Right.
So how can neurologists ensure that clinically silent yet rapidly fatal occult myocarditis is not entirely missed in these specific distracting scenarios?
Well, the only definitive solution lies in protocolized multi-system screening for absolutely every patient presenting with neuromuscular toxicity after exposure to an immune checkpoint inhibitor.
Every single patient.
Every single one. Because myocardial involvement can frequently be clinically silent, presenting without any chest pain or overt signs of heart failure. So relying on patient-reported cardiac symptoms is insufficient and dangerous.
Right.
The papers mandate continuous telemetry to detect early conduction abnormalities, strict serial troponin monitoring every few hours, and early baseline echocardiography.
So the baseline clinical assumption must always be that myocardial inflammation is actively present.
Exactly, until definitively proven otherwise through comprehensive and repeatedly negative cardiovascular evaluation. A neurologist simply cannot treat the skeletal muscle and ignore the heart in this patient population.
Okay, so once triple M syndrome is suspected, the immediate clinical priority shifts entirely to the intensive care unit.
Yes.
And in this controlled setting, the neurologist and the critical care team have to navigate this precarious balance. You are rapidly suppressing a hyperactive immune system while simultaneously mitigating an exceptionally high risk of opportunistic infections.
Precisely. And the absolute immediate first step in management is the permanent discontinuation of the immune checkpoint inhibitor.
No exceptions.
No exceptions. There is no clinical role for dose reduction or temporary suspension. The offending drug must be stopped completely.
Right. And immediately following the discontinuation of the drug, you must initiate a rigorous parallel evaluation.
Yes, parallel evaluation is vital. These patients are severely immunocompromised due to their underlying active malignancy, their prior oncological therapies, and their impending massive corticosteroid exposure.
Right, because administering high-dose corticosteroids will rapidly worsen any underlying smoldering infection.
Exactly. Therefore, neurologists must aggressively conduct a comprehensive infectious workup concurrently with initiating the heavy immunosuppression. You cannot sequentially wait to rule out infection and then begin treating the immune toxicity.
They have to happen simultaneously.
Yes, the diagnostic and therapeutic processes must happen simultaneously to prevent death from either cause.
Okay, so let's get into the specific pharmacological management. It begins with initiating intravenous methylprednisolone.
Right. The recommended baseline dose is 1 to 2 milligrams per kilogram per day. However, in cases presenting with fulminant myocarditis or rapidly progressive multisystem involvement, pulse dose intravenous methylprednisolone at 1,000 milligrams daily for 3 to 5 days is utilized.
And this massive corticosteroid exposure is the cornerstone of initial therapy to halt the cytotoxic T-cell activity.
Yes, but the clinical reality is that corticosteroids alone are frequently completely insufficient to halt the tissue destruction.
Right, so let's talk about the escalation protocol detailed in the papers because it is highly specific and aggressive.
It is. For any patient demonstrating significant bulbar symptoms, impending respiratory failure, or fulminant overlap syndrome, you must immediately initiate intravenous immunoglobulin, specifically IVIG, at a dose of 2 grams per kilogram administered over 2 to 5 days, or initiate plasma exchange.
And the papers explicitly and repeatedly state that clinicians must not wait to see if corticosteroids fail before escalating to these advanced therapies.
That is the most crucial point.
Right, because if I can challenge this for a second, the traditional stepwise treatment paradigm is deeply ingrained in all neurological practice.
True.
We typically start with corticosteroids, meticulously assess for clinical response over several days, and only then add secondary agents if the patient objectively deteriorates.
Right.
But if the known mortality triple M syndrome is about 44%, and the physiological respiratory decline happens in a matter of hours to days, shouldn't IVIG or plasma exchange be the absolute immediate first-line treatment administered strictly concurrently with corticosteroids rather than viewing them as a secondary step?
The clinical evidence provided in the papers supports exactly that conclusion. Utilizing the term escalation is actually dangerous in the context of the triple M syndrome because it implies a permitted period of observation.
Ah, I see.
Because the T-cell mediated destruction of the striated muscle occurs so rapidly, early and truly concurrent administration of IVIG or plasma exchange alongside the high-dose corticosteroids is directly associated with significantly improved patient survival.
So in the ICU setting, waiting for steroid failure is functionally equivalent to allowing irreversible myocardial necrosis or permanent diaphragmatic damage to occur.
Exactly. Now, for the severe cases that remain completely refractory to these aggressive initial measures, targeted biologics are currently under active investigation.
Right, like abatacept.
Yes, abatacept, which functions as a cytotoxic T lymphocyte-associated protein 4 agonist, is utilized to directly counteract the specific T-cell activation initially induced by the immune checkpoint inhibitors.
And it is critical to note for long-term management that re-challenge with immune checkpoint inhibitors is generally strongly discouraged.
Strongly discouraged. The established risk of triggering recurrent, highly fatal immune-related adverse events heavily outweighs the potential future oncological benefit once triple M syndrome has occurred.
Okay, so the immense complexity of managing these critically ill patients really requires seamless, continuous, multidisciplinary collaboration.
Without a doubt. The neurologist, the cardiologist, the intensivist, and the oncologist must interpret the rapidly evolving clinical parameters together. The parallel evaluation for underlying infection, the continuous telemetry monitoring for lethal arrhythmias, and the precise daily titration of heavy immunosuppression demand constant clinical vigilance from the entire medical team.
Well said. So to conclude our comprehensive analysis today, we will repeat the practical summary for you. Immune checkpoint inhibitor toxicities, especially the highly fatal triple M overlap syndrome, demand high clinical vigilance from all neurologists.
Right. Standard diagnostic tools like autoantibody tests and electromyography are frequently unhelpful, and they will lead to dangerous, potentially fatal delays if relied upon exclusively for diagnosis.
Patient survival depends entirely on immediate drug cessation, parallel infection screening, high-dose corticosteroids, and the early concurrent administration of IVIG or plasma exchange.
Ultimately, the clinical recognition of this severe overlap syndrome represents a critical evolution in both neuro-oncology and neurological critical care. The mortality rate remains unacceptably high, and our ability to mitigate this physiological crisis depends entirely on early clinical recognition and immediate, aggressive, multi-system intervention without waiting for classical diagnostic confirmation.
Right. And we want to leave you with a final thought to ponder as you return to your clinical practice. Given the established shared immunopathogenesis between thymoma-associated autoimmunity and toxicity induced by immune checkpoint inhibitors, could widespread pretreatment screening for subclinical anti-striational or acetylcholine receptor antibodies eventually allow neurologists and oncologists to predict and actively prevent triple M syndrome before the very first oncological infusion is ever given?
It's a fascinating question for the future of the field.
It really is. Thank you for joining us on the weekly Neurology Deep Dive. We remind you once more that this program is an educational summary, and you should read the full papers for complete clinical context.